Let's put 5 minutes on the clock and your time starts now.
Shall we go?
You have 30 more seconds of reading time, but you want to start? I'm happy.
Yeah, let's go.
Sounds good. So, what would be your main differential diagnosis and key differentials to consider?
Okay, so I broadly break it up into dementias, dementia mimics, and organic causes. So dementias are my Alzheimer's, frontotemporal, vascular, and Lewy body. My dementia mimics are multiple systems atrophy, normal pressure hydrocephalus, progressive supranuclear palsy, and Parkinson's disease. And then in terms of organic or other would be mental health, so depression, anxiety, primary psychosis, extremely unlikely. Bipolar disorder. Hearing deficit, vision deficit, hypo or hyperthyroidism, B12 deficiency, malignancy, in particular brain mass, medication side effects, and substance use. Tertiary syphilis is also differential for organics.
What further aspects of history would you ask Thomas and Margaret to help better understand their concerns and the most likely diagnosis?
Yeah, okay. So, first I want to get a... Forgive me, give me a second. I'd want to get a sense of Thomas's medical history, chronic diseases, medications, his own allergies. I didn't see anything listed there. I'd want to get an idea of their social setup. So, where do they live? Is it their own dwelling? Is it a unit? Who do they live with? Whether they have any services in place, whether there's any next of kin, helpful neighbors, kids who are helping them out. What Thomas's day-to-day is like. Is he still puttering around on the farm? Is he volunteering, men's shed, playing bowls, sitting at home? Physical activity level. A bit about his diet. Is he getting leafy greens? Is he getting red meat in there? Or is it just tea and toast? Whether his alcohol level, alcohol consumption level, his smoking, any substance use. Whether he's driving or not. Then I'd delve into the 6 aspects of dementia. So there's a few already listed, but we're talking about visuospatial. Is he getting lost in town? Is he getting disoriented to surroundings that he is normally oriented to? Memory, is he forgetting things, forgetting where he left his keys? Repeating questions, some of that's already mentioned. Language, is he forgetting words that he used to know, can't remember the name of a simple item. Complex attention, this is things like completing a task with multiple steps in it. Forgetting to buy things at the grocery store without a list. Complex planning, that will be making his appointments, not being able to plan a trip or a camping trip or a trip up to a big town, something of that sort. And social, is he withdrawing from his normal social circles, no longer going to men's shed, no longer going to bowls, things like that. And then I'm running through my differential and seeing if there's anything pointing to one particular cause. So frontotemporal.
What initial investigations would you request to assess Tom's cognitive decline?
Sure. So I would be requesting blood tests for my organics, so my thyroid function, B12, CRP and ESR, full body Es and LFTs. I do a CT, non-contrast of his brain, looking for mass, looking for involutionary changes. Syphilis serology, urinalysis, let's start with that. I don't know if Montreal Cognitive Assessment is part of the investigations or not, but that's what I'd run. That's probably where I would stop investigation-wise.
How would you approach management if the initial workup suggests early stage dementia?
Right. So management is pretty holistic here. In terms of pharmacology, if there's a vitamin D deficiency or something, which is something else I should have requested, and calcium, if there's any deficiency, we can top that up. but mainly it's probably going to be one of the possible Alzheimer's meds, like memantine, but that's to be started by a specialist. And I'll get back to that. What we would do is he'd probably need a home care package assessment, him and his wife, Margaret, to see what services they need in place now that he's not able to do certain things. Maybe he was the only driver in the family, things like that. He, as per WA laws, it's his responsibility to notify the Department of Transport that he has dementia, and he'll need yearly assessments. This is not to say I'll be taking away his driving license on the day. I don't do that too much. Home medicine review would be helpful if he's on more than five or more medications, and that can be done by a pharmacist. I would provide education briefly to start with, more on our follow-up appointment in 2 weeks, on what dementia is, that it's a progressive disease, that it doesn't really get better. There can be dips with infections, but mostly it's going to be a general decline. There are set things you can do to slow the process down. Good diet, exercise, memantine, controlling vascular risk factors, but mostly it's going to be a sort of a slow downhill. Unfortunately, written information, I would link them in with Dementia Australia and make sure they are part of that organization, because they get some good supports from that. If there are any defects in terms of low mood, if there is difficulty with walking or gait, allied health referrals can be done through a care plan to physio or psychology. And the main thing to do is to send him to see a dementia specialist or a gerontologist up at the hospital for a formal diagnosis and initial pharmacological treatment. Just let me have a think. I'd also mention thinking about an advanced health directive, and or assigning an enduring power of guardianship and attorney to kids or trusted next of kin, if and when Thomas becomes not capable of making medical and financial decisions for himself.
Now, you mentioned that you may find reversible causes. Are there any other reversible causes you can think of that you would want to address for this case?
Apart from the ones I already mentioned before.
Mm-hmm.
Well, any potential dementia is a potential delirium. I'd be hesitant to call a 12-month process delirium, but electrolyte disturbances and infections can cause that and could be corrected. I guess I haven't really mentioned multiple myeloma that can cause fogginess.
And did you want any of the questions read again? Or is there anything else you would wish to add?
Well, I was gonna give you more targeted history based on the differentials.
Yep, definitely. Far away.
Okay, so I mentioned frontotemporal. We'd be looking for personality change, disinhibition, gambling, buying really expensive, unnecessary things. Vascular is mostly, would be looking for more of a stepwise progression. Instead of a gradual thing, it's a big chunk, then big chunk again, then big chunk again. And we'd be looking for vascular risk factors, blood pressure. ex-smoker, or smoker, ex-smoker, diabetes, high cholesterol. The dementia mimics tend to give you motor problems, wide-based gait for the first three, bradykinesia, rigidity, resting tremor for Parkinson's. I'd ask him about his hearing. Does he have any hearing aids? They usually have hearing aids, but don't wear them. Vision. When's the last time we've been to an optometrist? Let's check your vision. Thyroid, constipation, diarrhea, feeling hot, feeling cold compared to everyone else, weight loss, weight gain, lumps in your neck. B12 is primarily diet related, but thinning of skin, bleeding gums, numbness, tingling in your feet, in your toes. Peripheral neuropathy. Cancer would be weight loss, fevers, night sweats. Brain mass would be headache that gets worse lying down and at night. That's persistent, not responding to simple analgesia. I'd go through his meds, see if there's anything sedating potentially there, and remove it. And substances, well, I'll see if he uses anything, but I don't expect him to. I don't know, you got me stumped. I'd probably offer to have a follow-up appointment in 2 weeks and bring some rallies or someone they trust with them, for breaking the bad news, for some support. I don't know. Let's just end there.
Excellent. And this is another one of those cases where, yeah, sometimes you just have extra time at the end. Very well done. In fact, even Chat's jumped in to give you a good job as well. Yeah, this was a pretty clear-cut, straightforward case of how do you approach and manage dementia. So I really liked your differential list. All very sensible. I like that you kind of broke down the things you'd be looking for as well, because that actually tied into that next question of what further questions would you be asking. You'd already actually answered chunks of that. By the time we actually got there. I also really love that you went in and actually mentioned, assessing their sleep quality and if need be intervening on that, because that's such a massive part that often actually does get overlooked. So big tick in the win box for that one. The screening, again, you ticked every box. The Montreal Cognitive Assessment as well is absolutely fantastic for these kinds of things. I think a lot of people fall back to the Mini Mental or GP Cog. Yep, I'm with you on that one. I think you get so much more useful information with the mocker, and I would strongly encourage everyone, if you're not familiar with using it, please get to it. And starting off as well with a non-con CT brain, fantastic. In terms of the management, as you said, it's that multidisciplinary approach. Many hands make for lighter work. And again, one of the things that was emphasised in this is also acknowledging that here we really have two patients. You've got the patient with the disease, but also the wife who is now the de facto carer. And I think that was good that you acknowledge that and, bringing in, seeing what other services we can get in place. So a really important part. And also love that you mentioned we don't have to take away this man's license. A lot of people with dementia are safe to drive as long as appropriate safety checks and balances are in place with those reviews to make sure that things continue to be safe. Sometimes even as things do progress, we do put on the restrictions of, only driving certain hours, certain distances, familiar environments. But I think it's a oversight that some people fall into the trap of. Dementia means they can't drive anymore. You're in Western Australia. Are you in a rural or urban centre?
Regional.
Regional? Yeah. I think you can tell because taking away someone's license is a big deal when you're not in a city. For some people, it's basically a death sentence. Very well done. There were a couple of times as well where I did interrupt, and that's the examiners have certain times where they have to ask certain questions, so don't feel like they're trying to jump in, don't feel like you're running out of time. Sometimes it's just part of the prompting, part of the schedule. And in those cases, like here, there's often time at the end where you can go back and add things in as well if you want to. If you're finding you're getting that kind of multiple times, you might need to just tighten up the answers a little bit. It may be they're after less detail and there's more questions they're trying to get through. So just bear that in mind. But otherwise, absolutely fantastic. I'm guessing you've seen patients with dementia. I don't know, call it a hunch.
One or two.
Yeah. Absolutely smashed it, mate. Again, very well done. You're going to fly through the next 2 weekends. Are you Saturday or Sunday?
Sunday?
Yeah, you'll be fine, mate. Well done.
Cheers.
I'll leave you to it. All right, so the structured feedback for this slide, and I'll fix this up again. I'll get this right one day, I tell you. So the competent candidate here demonstrates a thorough understanding of the differential diagnoses for cognitive decline and identifying those key reversible and non-reversible causes and outlining appropriate investigations. Describing the management approaches that include non-pharmacological and pharmacological, and communicating empathetically with the patient and spouse, acknowledging that that spouse is as much a patient here as the patient themselves is. Having that clear and supportive explanation and kind of follow-up plan, I was very happy again. If nothing else, always remember, always book in a follow-up appointment. Use the refs mnemonic to give you that little prompt right in the corner of every page. Always mention what are the red flags, what's the follow-up plan, when are we going to see each other again to follow up on this. It's the joy of general practice. We have sessions, we have multiple occasions we can see these patients. And of course, following along the evidence-based guidelines for this.